Good evening. My name is Bente van Berge and I am part of the research group of the Department of Plastic Surgery of the University Medical Center of Groningen, the Netherlands. I am very happy and honored to present to you our recent work, patient-reported outcome measures to predict treatment for Dupuytren disease. And none of the authors have a financial disclosure or conflict of interest with the presented material. Remote patient monitoring is upcoming. It could reduce inefficiencies and cut costs in chronic disease management. The number of publications on the subject is increasing rapidly, but only 7 of 272 studies on remote patient monitoring are published in the setting of surgical pathologies, and these few studies are focused on post-operative care only. In theory, patient-reported outcome measures, or PROMs, can also be used as a telemonitoring tool. So far, PROMs are mostly used to evaluate treatment results, and we hypothesized that PROMs could also be used as a tool to predict treatment. And when COVID emerged, we became more aware of the relevance of studying this. It could be economically or logistically appealing, especially in times of reduced outpatient capacity. So we studied whether we could use the URAM scale or the MSQ to predict treatment for Dupuytren disease in the following year. This study was a prospective cohort study based on longitudinal data of clinical and subclinical Dupuytren patients. Study visit took place every 6 months from 2012 to 2016 and annually since 2017. Patients completed the MSQ at each visit between 2012 and 2014 and the URAM since 2014. We included hands with Dupuytren disease and we excluded patients who were only treated before the start of the study in 2012 and untreated patients from the general population because they didn't seek medical care and are therefore not representative for the clinical Dupuytren population. Our primary outcome was treatment for Dupuytren disease. The instruments we used were the MSQ and the URAM. The MSQ contains 57 items on 6 subdomains. A maximum of 100 points can be awarded, and this represents an excellent hand function. The URAM scale comprises 9 items, and the total score has a range of 0 to 45 points. In contrast to the MSQ, a 0 points represents an excellent hand function. So we compared the URAM and MSQ scores of patients who will receive treatment, the treatment group, to the patients who have never been treated, the control group. For the treatment group, we selected a study visit and the corresponding MSQ and URAM score within 15 months before treatment. For the controls, we randomly selected a study visit and determined the corresponding PROM score. Additionally, we selected the study visit 1 year earlier within these 15 months and we calculated the 1-year change score. And for the controls, we did the same. After applying our in- and exclusion criteria, we included 133 hands of 111 patients for the MSQ analysis and 148 hands of 122 patients for the URAM analysis. These plots show that patients who will receive treatment within the following 15 months, the green boxes, have a substantially lower self-reported hand function than patients who won't be treated in the following 15 months, displayed in blue. And note that there is a large variance of MSQ and URAM scores in both treated and untreated patients. The MSQ before surgery showed an area under the curve of 0.79, corresponding with a likelihood ratio of 2.17. The results of the URAM were similar, with an area under the curve of 0.75 and a likelihood ratio of 2.12. The optimal cutoff value was equal to or less than 91 points for the MSQ and equal to or more than 2.5 points for the URAM. The 1-year change score appeared to have a poor predictive ability for both questionnaires. We calculated the likelihood ratios for all subdomains of the MSQ. The appearance of patients' hands and the activities of daily living showed likelihood ratios of 2.96 and 3.22, and also the domain of work prestation and satisfaction showed higher likelihood ratios compared to the total MSQ score. It's remarkable that the domain of hand function has a lower predictive value than most other domains. Our study showed that Dupuytren patients with an MSQ score of less than 91 points and patients with a URAM score of more than 2.5 points are around 2 times more likely to be treated within the next year. A 1-year change score of the MSQ and URAM is as predictive as flipping a coin. Although the likelihood ratios we found are not groundbreaking, we think that the use of a web-based URAM or MSQ could be a safe way to monitor patients remotely. It can help surgeons to invite patients to the outpatient clinic before patients seek for medical care because they have developed severe deformities. Instead of losing them out of sight, we can keep patients on the radar. And because there were only a few false negative cases, the chance of missing patients in need for treatment is small. And this indicates that using the MSQ and URAM as a telemonitoring tool is rather safe. A limitation of our study is that we only use PROM scores measured within 15 months before surgery, but we didn't study the predictive ability of scores 2 or 3 years before surgery, and this could yield different results. Another limitation of our study is that we did not stratify our patients for primary and recurrent disease. But on the other hand, we believe that it's clinically relevant to monitor patients with both primary and recurrent disease. So thank you very much for listening and feel free to ask me a question.